Good afternoon, you guys. We'll just give it some more time for everybody to filter in. Thanks. Hey, Dylan, thanks for being ready with the camera. How's it going? I'll join you.
I'm good. How are you?
Camera. Good. Let's see. We have our PGY4s that I want to wait for. They're at their physics lecture, so it's not uncommon for Richa to let me know when they're coming back. No, not a text. We have a bit more time. Who's giving lecture first? I don't see our teacher yet. Or is it Manuela?
Dr. Matesan. Yeah.
Manuela, hello. I see you on there now. We're just going to take a few minutes to do some resident announcements once our PGY4s come in, and then we'll hand the screen over to you guys, to you rather, just you, even though your name has more than you. Okay. Well, let's do one more minute. And to the nuclear medicine residents out there, thank you for your patience as well. Just a few general announcements for our diagnostic radiology residents. Numbers are creeping up. We'll just start in a minute. Dr. O'Malley asked us to say hello. He's not able to join. And I think Diana was going to pop in just to say hi too. We don't have that many announcements. I'll go ahead and get started. So where did they go? Let's see. I wanted to make sure everybody saw the email from Rad IT. They recently emailed out a job aid for Universal Viewer to help avoid PACS crashes. It's a workaround. So Peggy explained to the faculty that this will not eliminate all crashes for you, but it will help. So please follow the instructions in that job aid. It will be helpful. I also wanted to point out that next Thursday, October 29th, all the PGY5s should attend. We'll put this in the letter. So Dr. Katie Lowry will give a lecture at 3, a presentation on optimizing teaching. At 4, Dr. Mahmoud Mosabasha will come and chat just for not a lecture, but just an open conversation with everybody about Universal Viewer, etc. Please feel free to gush your comments, questions. Don't be shy. As always, just be diplomatic and professional. Don't be shy. And then finally at 5, Diana on the for the entire program will share with you our annual program evaluation summary. So we've already shown it to the faculty, and now we'll bring it to you guys. What else? Then finally, I want to thank our PGY2s. So Kara, Ashkan, and Dylan will organize this season's pre-interview virtual dinners for our candidates. So we're super grateful to all of you who will be participating, and Dylan is going to say a few words about that. The ARIS applications came out yesterday, so we've started digging in and reviewing the big stack of incredibly talented candidates, and I'm just super grateful for all of you guys for chatting with them on their interview days and the evening before. You guys are amazing, and they'll be super happy to meet you. So without further ado, Dylan, why don't you take over the microphone?
Yeah, so for those of you who don't know me, I'm Dylan. I'm a new R2. And I think it speaks to how weird things are right now that I haven't really met all of you in person yet. And here I am setting up Zoom dinners instead of pre-interview dinners for the new applicants. You should have received an email from me about a half hour ago. And all this information is in there. I just wanted to take the chance to talk to you guys while I had the platform before our lectures. So essentially, we're going to do hour and a half Zoom sessions on most of the Sundays throughout November, December, and January, just excluding all of the Sundays around the holidays. And they're going to be about an hour and a half long. I recognize that there's a lot of barriers, especially for those who are taking call or doing boards prep right now. So I appreciate, whatever time you guys can give us on those Sunday evenings. We're only aiming for about 15 residents per session, but more obviously would be welcome. And I know it's not an ideal situation to be trying to, meet applicants over Zoom. But I think that, my dinner here is what set apart UW from many other programs. And, hopefully with enough buy-in from us, the sessions can achieve the same goal. And, if kind of choosing who sits next to you in the reading room isn't enough motivation, Tess has been nice enough to provide $20 each resident to order out food in the nights of the Zoom dinners, or beer, whatever you want, I think. But we'll be emailing more with specifics. So I just want to thank you in advance for your participation. And if you have any questions or if you have any ideas on how to make this a more interactive and enjoyable experience, then we're always here to listen to you guys.
Thanks, Dylan. Do you mind if I chime in a little
Go
bit
ahead.
on this, just to reassure people, if you're wondering like, how in the world is this going to work? I think you guys have had some social gatherings by Zoom, and I know that it can feel maybe awkward in the beginning, but for instance, in the Women in Radiology group, we've had get-togethers for book clubs and a mentoring session, and there's a group of 10 to a dozen of us, and we just put the Zoom configuration so that we can see like the palette of all the faces, and it once the conversation starts, it's really easy, and it does feel super comfortable, and definitely a community is created. So I hope you guys have fun with it, and yeah, we'll give you some funds. We're not sure if it'll be through a gift card, for instance, like we're going to do for the candidates themselves, or if it'll just be a fund put in your Husky card account. But that's what we're going to do. And then Hoywan is chatting, Dylan. I think small breakout sessions work really well if it's a big group. So yeah, you guys can do whatever you want. But thank you guys so much. Appreciate it. So Dylan, are you going to have a sign up sheet? Is that what's in your email? Or
Yeah, it's a Google sheet that that just has places for people to write in their names. On the sheet and in the email, I just said, so since we're kind of limited by, to 15 residents for the reimbursement for the food, we have it capped at 15 per day. But obviously, if you can only make one day, then please sign up for that day as well. More the merrier. If there's another day that's open, then please, if you can, try to sign up for that day as well.
Sweet. I think that sounds great. Thanks, you guys. Any other questions or chats from the group about anything? Okay, super. Well, thanks. Good to see you guys. And Manuela, have a good time teaching. Appreciate it. Take care, you guys.
Hello, everybody. I'm not sure if you can hear me.
We can hear you.
Hello, everybody. Can you hear me?
We can hear you.
I was wondering if you can hear me.
We can hear you.
Yeah.
Dr. Matesan, we can hear you. If you cannot hear us, please look at the chat box or the volume.
Hello, everybody. Can you hear me?
Yes, we can hear you.
Okay. I will show a couple case-based images in a board review format from gastrointestinal and renal system. And I'm not sure how audience response will go, but I will leave you some time to think about when I will ask questions. And I will start with a case that you did not see images of this radio tracer at UDA, but we see something very similar. So it's a 39 patient with prior history of blunt abdominal trauma. And this is the study. Anybody have a guess can give a guess what study is this one? Anybody can guess what study is this one?
The HIDA?
HIDA scan. Yeah, HIDA scan does not have radio tracer uptake in the ribs. But yeah, the history. I just gave a little bit of history, so make sure you don't know before looking at the images what study it is. So it's the one that I before said it looks like a keychain, like it has liver and spleen if there is a spleen, and it has bone marrow uptake. So if you look at this one, it could be either the white blood cell or sulfocolloid of heat damaged red blood cell. And this is a patient with spleen removed after an abdominal trauma. And there is this study, it's the TEC red blood cell scan done for evaluation of these soft tissue nodules visualized intra-abdominal. So if I do not think at the board, if they will give you a study like this, they will not put sulfocolloid or white blood cell among other options, because it will be very hard to say to tell them apart. However, there is a way to say which one is sulfocolloid and to differentiate between sulfocolloid and then the red blood cell, because there is a highly specific splenic sequestration of damaged RBCs. So the splenic tissue is way hot on damaged RBCs compared to the sulfocolloid. So this was he damaged the RBC scan, 25 millicurie, injected, and then 60 minutes later, the images are obtained. The RBCs after labeled by ultratag are kept at the temperature of 49.5 degrees for 20 minutes to be damaged. And apparently other Utah is doing this study, but I have not seen at the UW, and many other centers are not doing it. But sulfocolloid is the replacement of this study, but just wanted to make sure you've seen at least one, probably you've seen in the textbooks. And this is like a companion case. It's a case from Children's. I don't know if you've seen that one presented this year. And it's a 3-year-old patient with left upper quadrant pain. Ultrasound did not show a spleen was absent, and it was a heterogenic mass called abscess. And sulfocolloid study was done and revealed just a little bit uptake at the capsule of the mass, and it was a wandering spleen with torsion and infarction of the spleen. And I will go back. Just wanted to make sure I will start with this one so I have time to show you the RBC scan, since you probably never seen before. At least at the UW didn't. So I will show a couple HIDAS cases, because this is the most cases of abdominal pathology that you will see at in NUC-Med, or HIDAS scan, I mean. So HIDAS scan, I will quickly remind for those that are just starting to read NUC-Med studies that it's a misnomer, and we're actually doing BRIDA this time, and we're using mebrofenin, and the B comes from the best ones, and that is related to the level of the bilirubin at which you can still do the study. If you have a bilirubin higher than 8-9, it's very poor quality studies, and in the books it says for mebrofenin you can do up to 30 milligrams per deciliters. At least probably better than other, but I don't think you'll have much information when you are at 20 milligrams of bilirubin. And when you look at the HIDAS scan at this is an image at 1 hour. You will see the hepatic left and right hepatic duct, and left hepatic duct is more prominent. Do not confuse it with a leak. And then right hepatic duct, and then common hepatic and common biliary duct, duodenum. And then I think one weak point that we have when we read the HIDAS scan is that we're not looking that much at the bowel to make sure there is a good progression towards the small bowel, because you can sometimes catch a partial biliary obstruction, seeing that there is not enough radiotracer that passed to the small bowel. And just a case to show that what I said, that the radiotracer is not that good, is not well excreted when the bilirubin levels start increasing. And this is a patient evaluated for abdominal pain, and I will let you look at the images for a couple seconds. And for those who didn't read the HIDAS scan before, we have the liver here and the cardiac blood pool here, and we have the weird radiotracer presence, which we need to figure out what it is. And based on the images that I show you only first 10 minutes from the HIDA, what do you think, what can you conclude based on these images? If anybody wants to give a try. Anybody thinks it's a biliary leak? Or the study is non-diagnostic? Or they want to do a SPECT CT?
SPECT.
Yeah, SPECT is always good. And it's not necessarily a wrong answer, but what I was getting to, that based on this prolonged blood pool, for sure, there is some, it's too long visualize the blood pool, so there is some degree of liver dysfunction. I'm showing you the rest of the images up to 60 minutes, and this structure in the right flank, it's right subhepatic region, it's less and less visualized, and the blood pool is less and less visualized. So it is a it's a blood pool image in a patient with portosystemic collaterals. What I was trying to, teaching point I'm trying to make is that you should always look at the cardiac blood pool and make sure up to 5. They say in the books up to 10 minutes, normal patient, by after 5 minutes, you're not gonna see the cardiac blood pool. And because you don't see the biliary excretion, you cannot assume that this is already a leak because it's not yet radioactive bile excreted. And just very quick for those that didn't read the HIDA scan, we have a couple points to checkpoints when we look at the images. Cardiac blood pool has to not to be visualized after 7-8 minutes. Normal visualization of full common bile duct. Gallbladder ideally to see by 60 minutes. If you don't see gallbladder by 60 minutes, you eat, and it's a patient that it's supposed to exclude the acute cholecystitis, you either inject morphine or wait delayed images up to 4 hours. And then also I mentioned already small intestine needs to be, just make sure there is enough radiotracer excreted in the bowel. And normal progression based after the midline. So back to our case, this is first 30 minutes HIDA scan, and I am not sure I can see a radiotracer in the usual gallbladder region. And this is the next 30 minutes, so up to 1 hour, it's still not visualized. What is the next step after we do the dynamic 1 minute per frame HIDA images? We do lateral images, right? So we do right lateral and left anterior oblique, and maybe there is a bowel, but not sure. I mean, I'm not 100% sure this is a gallbladder. So yes, next step is the SPECT CT. So we did the SPECT CT, and what happens is that gallbladder is vertical oriented, it's anterior to the duodenum. So sometimes it's hard to say, yes, I see the gallbladder, but just wanted to encourage you just to order a SPECT CT, and it's all much easier to interpret the images. And this is another case, patient with, actually it was sent to evaluate for acute cholecystitis, and the gallbladder is visualized, but it never progressed to the midline, and it went to the right paracolic gutter, so it was correctly read as gallbladder perforation. So I just want to remind you, in a patient that do not have post-surgical changes, you should make sure that you see normal progression towards the in the jejunum. And this is different than the first case, because the first case, these are very early images. So another case of biliary leak. It's a patient with trauma, I think motor vehicle accident, and it was sent to evaluate for peritoneal leak. So gallbladder was visualized a little bit, maybe some too intense radiotracer in the gallbladder fossa. And then we just did the 4-hour images when we were not sure we can see a leak anywhere else. And it was some liver laceration that we could see on the 4 hours. And there is this region that it was not like that on the 1-hour image. So next step, it was SPECT, because we actually didn't have a CT at Harborview. So if you look, there is a radiotracer accumulation very in the delayed images, in the lesser sac, lesser omentum. So I think the teaching point that I wanted to make is when you look at for the biliary leak, always take, if it's negative, take delayed images, because it might be like a slow rate of leak. And then you need 4 hours, 12 hours images to prove it. To prove it that it's actually, to try to prove it that it's not a leak, because it might be positive on delayed images. And this is a patient, very interesting case. It's a patient that has cholecystectomy, young woman, and came back with abdominal pain couple days later. And he had that HIDA scan. And what was interesting in the HIDA scan, he never progressed to this site of the jejunum. And he was thought initially, oh, it will be a leak in this region. But then she, I think after 1 hour, she went to use the bathroom, and then she came back. And then after she came back, everything that was on the right side initially in this one, it's the radio tracer, is flipped on the other side. And is this a normal variant described in the literature? Because jejunum has a long mesentery, it can be normally flipped on one side, on another side. And actually, it's not based on the bowel that we say it's malrotation, was not leak, and it's not malrotation because the SMA and SMV has a normal relationship. In this patient, we had a prior CT available. And then one more case of the HIDA scan is this patient who is post-transplant, who has radiotracer accumulation outside of the body, because body is kind of up to here. So the CT was done the day before. And my question for you is, what drainage tube do you think is this one? You think it's a subhepatic JP drain, external T tube, internal biliary tube? So it was read as a normal on CT, and the only teaching point that I'm trying to emphasize is like maybe we have time, look at the surgical notes, see what kind of tube the patient is supposed to have, because this one look more like a tube that is trying to be a T tube going from the common bile duct outside, but didn't really make it. But it was actually an internal biliary tube that perforates. So it was read as normal, but on a HIDA scan, it's very obvious that it goes out. It shouldn't go with the internal biliary tube. You shouldn't have bile outside of the chest wall, abdominal wall. Okay, and I just put a couple types of tubes. JP tube drain, I think, is the most common one that we see. And it was duodenal perforation. It goes outside of the duodenal lumen. And that's where it's supposed to be way higher, but it migrates. And our ERCP images is showing the extravasation. And one more like pitfall on when you do the HIDA scan, if this is a patient with renal transplant and they do biopsy of the liver, and this patient had a leak at the biopsy site, which result in time. In the ERCP, it's hard to prove that one because in the ERCP, you inject in the central biliary tree. So quick couple teaching points that I was trying to emphasize. Spexity, it's important. If not sure, do a spexity delayed image. It's important if you wanna look at a leak. And blood pool also, it tells you if it's gonna be a study that you will have to take delayed images because it's not excreting as in a normal person. And then check the bowel. And then the most important thing, maybe if you could remember from this lecture, is that the amount of radiotracer in the jejunum, it's important. If everything stays in the common bile duct, just couple dots, yeah, you see that the bowel at 2 hours, oh yeah, it's bowel here, so you don't have to worry about, yeah, but it's not enough amount. So this patient had stones in the common bile duct. And then just for a couple quick points for the board, they might just to remind you that when you suspect acute cholecystitis, you can have the RIM sign. And if you don't see, the normal protocol is you don't see the gallbladder, at 60 minutes you inject morphine, and then 30 minutes later you can, if you don't see by 30 minutes the gallbladder, then it's probably acute cholecystitis. And this patient has also the RIM sign, inflammation at the inferior aspect of the liver. And quick question for you. Visualization of the gallbladder basically exclude acute cholecystitis. Is this true or false? It is probably true for calculous cholecystitis. Sensitivity is very high, close to 100%, not quite there, but 98. But if it's false, if you are talking about acalculous cholecystitis, because you might have acalculous cholecystitis and you see the gallbladder on the HIDA scan. Don't forget the dilated cystic duct in a patient with obstruction of the cystic duct. And this case I already showed before, so I will just go quicker. And then just to remind you, if the patient did not eat for 24 hours, we give CCK before the procedure. And if you see the gallbladder and you want to calculate the ejection fraction, you can give CCK. So it has to be more than 38% at 1 hour ejection fraction. And morphine you are doing to evaluate for acute cholecystitis, and it's 0.04 milligram per kilogram. And the rule is no bowel, no morphine, just not because you don't want to miss the biliary duct obstruction, but you don't see the bowel, yes, you can give CCK. And phenobarbital, it's usually give 5 days before in cases that newborns that biliary atresia is suspected. And this is the case that I wanted to show you with a newborn with suspicion of biliary atresia. You see the cardiac blood pool prolonged, and you don't see excretion in the bowel, and you are even at 24 hours you don't have the excretion. So it's if the negative predictive value of the study is good. Like if you see the bowel, it's not atresia, but if you don't see the bowel, it's probably atresia, but it still can be severe hepatitis. And if you don't have excretion in the liver, it's what it's called a hepatogram, persistent hepatogram. This is a patient poster. It's an adult patient. He had choledochojejunostomy, and the suture was edematous. And other things that you can see on HIDA scan, it's the biliary cyst, choledochal cyst. This is a case with fusiform dilatation of the common bile duct. It was type 1 choledochal cyst. And just a reminder, there are 5 Todani classification, type 1, fusiform dilatation of the common bile duct that I've showed you the images. And it can be like as a diverticulum, as extrahepatic, supraduodenal diverticulum, and it can be intraduodenal dilatation of the common bile duct, choledococele. It can be intrahepatic and extrahepatic, and then finally the Caroli disease with intrahepatic. There are sometimes they ask this question on for boards about the esophageal motility. We do not do this. We are not doing this study commonly at the nuclear medicine department, but just wanted to show you just quickly what to look for. Like transit time, it has to be less than 15 seconds to be a normal esophageal motility. So they might show you an image like dynamic image, 15 seconds per frame after the patient take a semi-solid meals. And then it can show you the curve, how we after 20 minutes of imaging. And then of course this is very abnormal, and then I think you just need to be familiarized with what is normal, with what is abnormal. So this is seconds, so normal it will be less than 50 seconds. So after the food will go to the entire esophagus. In achalasia, it will stay over there, and spas will go like that. So I think you just need to be familiar with these 3 types of images. And we will change, just a quick reminder for GI bleeding scan, you will do with RBC ultra tagged. And you do dynamic images 1 minute per frame for 1 hour. And one of the pitfalls that sometimes there is, you basically what you see is the blood pool in the vessels and in the liver. So you are, and sometimes varices can look and be a little bit like a source of pitfalls. One of the pitfalls that they ask on the exam is penile blood pool, which can be confused with rectal bleeding, so you have to ask for a lateral view. And another source of like a pitfall is free pertechnete. So you do not call bleeding if you see uptake in the stomach. It's free tech, and how you can confirm is to visualization of the neck, thyroid uptake in the neck region. So we will just change a little bit topic here, and I will show you a gamma camera with the collimator on place. And you have this red stuff. It's the flood source cobalt 57 that the tech is using every morning. And my question is to check uniformity. My question for you is this extrinsic or intrinsic uniformity that they are checking every day? So extrinsic mean with the collimator in place and with the flood source, and intrinsic mean you take the collimator out. And if I'm telling you that this they are doing every morning, then it's more likely to be extrinsic, because I don't think they want to take the collimator out every morning. So the tech came in the morning and did uniformity, extrinsic uniformity, and the detector passed. It has to be more than 90%, 95% uniformity. So after she did the extrinsic uniformity with the flood source of cobalt 57, Jen did for me today a picture so you can see how it looks like. First patient came and it was a GI bleeding study. And I have this first 20 minutes and then up to 1 hour images. And based on these images, I just put one from the first 20 minutes. And then after that, what do you think findings are consistent with? Do you think it's upper GI bleeding? Do you think it's SVC obstruction with systemic collaterals, or a technical error, or a lower GI bleeding? Anybody? Anybody wants to pick a choice, pick an answer? So this is a technical error, and what happened? The tech came in the morning, and she did the extrinsic uniformity with the flood source cobalt 57. And what happened, in order to do that, she has to put the photo peak in the for cobalt 57. And cobalt 57, it's 122 keV, the photo peak. And the way I remember it doing every day 122, it kind of repeats the two. And then tech, it's the 140. So she left the photo peak in the region of the cobalt. So it not in the region of 140 keV. So it took a lot of Compton scattering. So the images were not good first 20 minutes. And then she noticed, and then she changed it to 140. She put it back. And the way I remember cobalt 57 every day, a flood source, it's 122, so kind of repetition. And then just a reminder that there is intrinsic uniformity and then extrinsic uniformity. And intrinsic, they're not doing daily, they're doing weekly. And then they're using a point source. And for flood source, it's for extrinsic uniformity. So couple things that I, just some pitfalls that I want to mention, that if you, in order to call it a bleeding, you have to increase intensity over time. Activity needs to change over time, conform to the intestinal anatomy. And I think most common false positive are varices, and then AVM grafts at AVM malformations are also common. Okay, and I think one last case of the gastrointestinal. I have 5 minutes for dinner. So anybody can tell me which study is this one?
protected tape.
Yeah, excellent. So many times when I show these images, people say RBCs. So what happened, you can see the blood pool at the beginning, but RBC has a half-life up to 24 hours. So you should be able to see the blood pool at the end of the images, but these ones are, the blood pool actually goes away by 1 hour, and you see the stomach. And when you see this, can you see the stomach? You can think at two different studies. It's either two different radio tracer, either iodine or free tech. So free tech you can see either with Meckel scan or with free tech from other studies like RBC, radio labeled RBCs. So this one is a Meckel scan, and there is a focus in this region. The rule in order to call it a Meckel is supposed to show up on the same time with the stomach, and it's supposed to in the center and then stays bright, similar with the stomach, but this one kind of goes away anyway. It was done, they did a SPECT study, and it's the urinary activity. And I want to show you, I think I can go up till 45 minutes. So I want to show, this is just couple positive studies of Meckel diverticulum. And it's a case with the Meckel diverticulum when you could see the persistent vital or intestinal artery. And I will close this one, and I want to show you, I was supposed to show you a couple renal cases. If I have time. Okay, genitourinary system. Why bother to do nuclear medicine images when you have the CT and MRI? The idea is that nuclear medicine gives more functional information than the other studies. And when we talk about the radio tracer, I think you have to remember mainly MAC3, and the 3, I think it will help you remember there is a dynamic image and has blood flow, blood pool, and excretion, and the MSA is a static, and as you should supposed to help you remember that it's a static, and the image is obtained at 2 to 4 hours after injection. So you're not gonna see, if you see a dynamic image, it's not gonna be the MSA, it's gonna be MAC3 or DTPA. And we don't do DTPA, but there are centers that they do DTPA with a glomerular filtration agent. And I think you should remember this one too. So MAC3 and DTPA dynamic, and DMSA static. And for those that didn't read yet, renograms, you have 2 sets of images. One is the blood flow phase. The tech is acquired 1 second per frame for 1 minute. And then you have cortical uptake, and then excretion phase. And then for cortical uptake, you are using between 1 and 3 minutes to calculate the differential function. And based on this graph that I will show you, time to peak normal is 3 to 5 minutes. And then you have the clearance phase, excretory phase. And then after Lasix, ideally you should have a time of when the radio tracer activity decrease less than 10 minutes. I will explain more about that later. And this is how, when you have 2 curves to look at it, and then there is one in seconds, that's about the blood flow, and then you have aorta, and you have the kidney between 1 to 3 seconds, and it should be symmetric immediately after the aorta. And then you have the second graph will be the renogram, and you have the radio tracer uptake and excretion. And you have the time to maximum cortical uptake 3 to 5 minutes, and then excretion. This is like a normal study. And then you have couple other possibilities of abnormal studies. You have the diuretic T1/2, and then diuretic T1/2 is the time from the moment you inject Lasix until the moment the activity goes to half. So normally it should be less than 10 minutes. This is a normal concave response. This is a slow response, but still less than 10 minutes. And this is no response here. And T1 half more than 20 minutes. And this is indeterminate between 10 and 20. And I think I will have time to show maybe one case only. This is a patient, this is a renogram, and that's the blood flow phase. And you see the radiotracer accumulation in both kidney, but the upper pole of the right kidney is doesn't have good vascularization. And most of the time when you see decreased blood flow, it's because the function, it doesn't necessarily mean it's obstructed, but the function is decreased. But in this case, they were like the cause of the decreased function, it was obstruction. And then the lower pole, it looks like has a normal uptake. And then on the uptake, cortical uptake phase is very delayed uptake in the upper pole of the right kidney. And eventually it takes up radiotracer, but very delayed compared to the lower pole. So this, and then post-void images, I think they can, they are very important because they can show up like a kidney that you think it's obstructed. When you do the post-void images, it might empty because the bladder was full before. So you have a case which is the duplicated kidney, like the one I show. It's good to do region of interest for the upper pole and for the lower pole separately. And and then it shows you, for example, here that lower pole, it has slightly prolonged uptake, but it has good excretion. But upper pole has less function, less height, and then has only minimal response to Lasix. So this is decreased function in a longer standing obstruction, and it was a case of duplicated collecting system. And then we just wanted to remind you this Weiger-Meyer rule. Upper renal moiety has ectopic insertion medial and inferior, and frequently ends in urotheroceles. And then lower renal moiety has orthotopic insertion lateral and superior, and typical reflux. The lower one is the one that refluxing. And you can see a scintigraphic dropping Lilly sign, kind of similar to the urogram, where the orientation of the renal, like of the kidney, it's kind of inferolateral, not in the normal location, not in the normal angle. And I think Dr. Vesselle is supposed to start at 3:45.
Yes. Hi. You need a couple more minutes?
No, I mean, I just started renal, so if you can just go ahead, because I will stop here and you can
You
start.
started renal. Was renal your whole subject?
Well, I had the GI. I showed a couple cases and renal too in 40 minutes. So.
Oh, yeah, it's too much to cover.
It's fine.
Well, take how much time do you need?
Maybe 10 more minutes. That's a lot.
Right, please.
Can I go 10 more minutes?
Please, go ahead.
So I will show a case of renal artery stenosis. I know we don't do many of these in clinic, but they occasionally you have cases, and they ask questions on the exam, so you have to be familiar with it. So in order to evaluate for renal artery stenosis, if it's significant, first functional significance, we are doing the captopril study. It can be done with technetium DTPA and MAC3, and I said there are two tracers that we are doing dynamic images, but the UW will see with MAC3. And there is separate criteria for DTPA, MAC3, because one has glomerular filtration and the other one has tubular excretion. So patient needs to be prepared with the couple medication needs to be stopped. Like ACE inhibitor should be stopped couple days before, and angiotensin II receptor blockers and calcium channel blockers needs to be stopped before. And first patient is doing a renogram doesn't need to have Lasix, and then you have a baseline blood flow, and the other phase like cortical uptake and excretion. And what I was trying to, like for example, this case, if you look at the blood flow phase, you can see both of the kidneys, and you cannot tell, oh, I think this one is the one with renal artery stenosis. And my point is, blood flow phase is not sensitive enough for diagnosing the renal artery stenosis. So if you don't see it on blood flow phase, don't say, oh, probably it's not significant, because it's not sensitive enough. So this was the right kidney that was supposed to be investigated for the renal artery stenosis, and it has a good cortical uptake, and it has a okay excretion, a little bit slower. This is the baseline study. And after that, patient is taking the oral captopril, and the images are taking again 1 hour after the captopril. And again, the blood flow studies after the captopril, I cannot tell which one is gonna be the one that has renal artery stenosis. So I just want to emphasize again, blood flow phase not sensitive enough for 1 second per frame to show which one it's the one that doesn't have enough flow. So, and then it's the right uptake that the right kidney that I'm looking, and there is cortical uptake as before, but doesn't excrete as nice as before. So I will just put the studies next to each other. And these are not color coded. So one is green and one is pink, but the same kidney. So we are gonna say that this is a high probability for renal vascular hypertension due to the renal artery stenosis, and this is the excretion before captopril, and that's the excretion after the captopril. And there are a couple criteria that they, even visually, if you see one is getting worse, unilateral one getting worse in excretion, you can say, yes, it's suspicious for renal vascular hypertension. That they went ahead and they quantify this one, and they say if the differential function between the right and left kidney changed by 10%, or if the time to peak increased more than 2 minutes, it's suspicious for renal artery. This one changed from 9 to 13 minutes, so it changed by 4 minutes the time to peak. So this was suspicious for renal artery hypertension. And then MR images show high-grade renal artery stenosis, and patient was stented. And I think for the exam, if you cannot remember anything, please look at these criteria and make sure you know those for MAC3 and DTPA. What's the changes based on which we are making diagnostic, the renovascular renal artery stenosis, either time to peak increased by 2 minutes or 10% change in relative function for MAC3, which is tubular excretion, and from the DTPA, which is glomerular filtration, is reduction in uptake more than relative uptake left to right kidney more than 10%. Just very quick couple cases of renal transplant evaluation. Occasionally we see these cases in clinic, and I just put couple Aunt mini cases. And this is an image of a normal post-transplanted kidney in the left left iliac fossa, because this one are images, anterior images in transplanted patients, and has good cortical uptake and good excretion, so doesn't retain. So it's a normal case. This patient was sent for suspicious of ureteral obstruction, but it excreted actually very well, so it was not a problem. And when they send it for you, the most likely indication that you are gonna see either to differentiate ATN for obstruction, usually other medical problems like rejection, they will do the biopsy. And this is a case, patient received a donor kidney transplant, cadaveric transplant kidney. And then it came with increased creatinine 3 days post-transplant. So blood flow phase, it shows that the kidney has a relative okay vascularization, and it has cortical uptake, but it does not excrete. And in a transplanted kidney, when you see this pattern of not excreting, it could be either ATN or obstruction. And the way you are telling which one is the difference, first of all, the renal pelvis is not dilated. But most important, if you have such a high-grade obstruction that it's not excreting, you will have way worse the flow. But this one, the flow is relatively okay. And it was called ATN, this case. And actually the attending went on and did delayed 1 hour images, but it still did not excrete it, because if it's obstruction, eventually it will, unless it's a complete obstruction, will excrete. So it was a case of ATN. Another case that I wanted to show is kind of like an aunt mini. You have the blood flow phase for the kidney, and then you have the cortical uptake and excretion, which is missing. So I said that if the way you say if it's ATN or obstruction, it's that on obstruction, the vascularization phase is way worse than in the ATN. But here, vascularization is like you don't see the kidney for at all for the first 2 minutes. So it must be something more than just high-grade obstruction, and the kidney is not actually that much dilated in the cortex. So this patient has a Doppler ultrasound, and it shows the diastolic reversal of the flow in the renal artery, and the renal vein, medial renal vein is not visualized, and the venogram show delayed absent flow. And then after repair of after elimination of the venous thrombi, it's improved. So this is a case of renal vein thrombosis, and I think you should remember, like in a transplanted kidney, if you don't have if you have such abnormal flow, it's either renal artery or renal vein problem. But renal arteries, you just see a hole, photopenic hole, and in renal vein, you will see some kidney, but very delayed. And probably this is the last case I will show. I will let Dr. Vesselle present. So if you want to look for rejection, it's good to have images immediately post-transplant and delayed images post-transplant. And this is a patient 1 month post-transplant, 6 months post-transplant, and you can see that you can see in the blood flow phase visualization of the kidney by significantly decreased in the 6 months post-transplant. And it's also a plateau, has cortical uptake but not excreting much. And the Doppler showed that there is no vascularization of the upper and lower pole of the kidney and decreased vascularization. And this was a case of acute rejection. And I think I will I will maybe give you a couple minutes of break, and then I will let Dr. Vesselle present his topic. Thank you.
Thank you, Manuela. Residents want to take a couple of minute breaks? Break?
Sure.
I'll share my screen and let me know when you're back. Are you able to see my screen?
Yep.
Okay. I'll wait a couple of minutes. So, this is supposed to be attended by first and second year radiology residents, but I've realized the whole crowd is here pretty much. So hopefully there's something of interest for all. I tried to put some more introductory material this time. Shall we get started?
Let's do it.
Okay. So I've been tasked to talk to you about SPECT-CT and PET-CT, and these two hybrid imaging tools share certain concepts in common, and so I will address that. Before that, we're going to start with some general concepts. And so what's molecular imaging? Well, it's any method that permits the measurement of a molecular biologic process or any functional information in vivo. Basically, all nuclear medicine imaging qualifies as molecular imaging. And as you know, in nuclear medicine, we have a diagnostic aspect and a therapeutic aspect. The diagnostic aspect is basically we have a certain molecule that we're going to radiolabel with a radioactive atom, and it's going to allow us to trace a certain physiologic principle. And we have 7 or 8 for PET that are clinically approved, and over 30 in SPECT, scintigraphy. And for therapy, we're not talking about here, the other radioisotopes are used that have different emission characteristics, usually betas that deliver a very large dose to kill, in general, cancer cells. All right, let's take this first example. Feel free to interrupt and ask questions. This is a bone scan. Basically, for those who have not rotated in nuclear medicine yet, bone scan is a simple exam, one of the simplest we do. We have a patient with a complaint that is potentially musculoskeletal, and we inject intravenously a product called technetium-99m, MDP, which stands for methylene diphosphonate. It quickly this radiolabeled product quickly biodistributes throughout the osseous skeleton, and it is chemoadsorbed to the hydroxyapatite matrix of bone. Afterwards, we wait about 3 hours to 4 hours before scanning patients. Why? Even though the product is bound to bone, within first 20 minutes, we are giving this extra time for the kidneys to clear the soft tissue component of the tracer that has not been bound to bone. This way, the bones stand out over the background better because the background is less warm. And MDP is going to bind to any bone that is alive. That's where you see all the bones, but also in greater proportion to any area where new bone is being laid down. Namely, if you have normal growth, this is a 13-year-old male, so you see the growth plate in the distal femur, proximal tibia, in the proximal humeri, in the wrists, etc. So that's one way by which MDP is going to increase in localization, new bone formation in a normal physiologic process, but also in response to any abnormality. It could be in response to a fracture, an infection, it could be in response to a tumor, it could be primary or metastatic, etc. And there are also some physiologic principles where you have diffuse increased uptake that that has been discussed by one of my colleagues. So this is a bone scan, 13-year-old football player with low back pain. And if you look at this, you wonder, there's a little focus here of increased uptake. It's pretty subtle, and he has a little bit of a rotoscoliosis to the right. So hard to know exactly what it is. So what do? We do what's called a SPECT imaging, single photon emission computed tomography, and I will explain the principle of acquisition of these images in a second. We use the same biodistribution of the product, but instead of looking at the images with frontal and posterior camera heads, we're going to have the camera heads rotate around the patient, looking at a certain area of interest from multiple angles, from which we can reconstruct tomographic images. And in this case, you can see on the right, there is a focus of very avid uptake of radiopharmaceutical, and you see it here. It's pretty tough to know with just these images where it is. So this was a case that had been done a few years ago at Harborview, prior to the deployment of a hybrid SPECT-CT. So we said there's a focus of marked increased uptake, but in this location, it's a little tricky to know whether it could be a bad facet joint that's inflamed or potentially a pars defect in a 13-year-old. And patient also had a CT scan a few days later, and it shows obviously a clear pars defect at this level and correlating with this. But the fact it's not in the same gantry creates a delay in the imaging and coming up with a conclusion. You might say, well, since the CT shows the fracture, why do the bone scan? Well, what you need to know is experience has shown for physiatrists and sports medicine folks that if you have a fracture, what matters is whether it is hot or not. If it is hot, that means that the bone is still attempting to heal itself at the fracture site. And therefore, this patient will benefit from bracing. And they get braced between 6 weeks to 6 months time. The exact amount of time needed for bracing is actually controversial. And there's not a well-established standard for that. And once the patient is no longer in pain, they can start reestablishing some light sport activities. So, but if it had not been hot, what would have happened is it would mean that this is old and there's no chance at future healing, and therefore bracing would not be helpful. Nowadays, we have SPECT-CT systems that provide the advantage of performing planar imaging, as well as SPECT imaging, as well as a CT without the patient having moved, and the CT can be overlaid with the SPECT image. This is another teenagers with lower back pain. Again, a posterior element area of increased uptake. This is color rendered, and it overlaid exactly over this facet. This facet joint looks totally normal by CT imaging. It just meant that there's a flare-up in a facet. In a case like this, there's no point in bracing. The patient is put on NSAIDs. The advantage of having both exams done in the same machine, the same gantry at the same time, allows us to basically come up with an answer right away. The protocols we have developed in teenagers is such that if there had not been any abnormal uptake in the lumbar region, we would not have done the CT scan, even low dose. There's no point going to look for structural abnormality if there's nothing warm. In this way, we avoid for patients to get abnormal, not needed radiation to their pelvic organs, and particularly important in young patients. Such a process cannot be really applied to adults because most adults are going to have some form of degenerative changes in discs or in facets, causing the bone scan to light up in multiple areas. But in young people, they're not supposed to have anything lighting up. And so therefore, we can do SPECT without the patient moving. We check the images. If there's no abnormal uptake, we don't do the CT portion and avoid the radiation. The other advantage of this approach is we can tailor the CT image even to a small field of view if we want to, based on the area that is hot, further reducing the radiation dose. Another example of planar nuclear medicine and SPECT application is an older case of a patient who had panic attack, palpitation, and elevated catecholamine levels. On the planar imaging that was performed with a tracer called I-123 labeled MIBG, meta-iodobenzylguanidine. This had shown faint localization here, I would say faint, okay? But after SPECT imaging, you could clearly see that it was localizing here on SPECT, here's on overlaid image, in a enlarged left adrenal gland, okay? The patient underwent a left adrenalectomy and the catecholamine levels normalized. This was a pheochromocytoma. So how do we go from this planar image to this SPECT image, and why is it easier to see an abnormal localization of radiopharmaceutical by SPECT than it is with planar? So let's go over some basic imaging principle. When we do planar imaging, this is the idealized patient, basically a cube with a hot lesion within it. It could be the adrenal that I showed you, or it could be a pars defect. This is an area where focally the radiopharmaceutical we have injected localizes in higher concentration than in the surrounding tissue. That's basically the premise here. When we do a planar imaging, like a bone scan, for example, we put the camera head in front of the patient. Rays come from the biodistribution, some from the soft tissues, some from the hot lesion, and they distribute over the gamma camera head, causing a flat 2D image where the local concentration of the counts of photons is pretty much proportional to what is in the tissues. But notice how this is a case with pretty good contrast. When we look at a profile across this slice or this flat image, we can see that the counts go up over the region of the lesion. but we also have some counts in the background. You know, this background tissue is light gray. There is some soft tissue localization, non-specific, of the radiopharmaceutical. As I mentioned in bone scanning, that's why we wait 3 to 4 hours to minimize this. Nonetheless, detecting this lesion by planar imaging means being able to see a higher concentration in this lesion compared to the background activity. So we're looking at detecting this step here relative to this background. And this background is due to what's in front and what's behind the lesion, okay? So here we have a moderate tumor or lesion to background, and we're still able to see it. But in some of the instances where the concentration in the lesion is not much higher than that in the background, it's going to be tougher, and we're going to need SPECT. So what happens in SPECT imaging? Instead of doing a simple whole body bone scan, for example, where camera head is in front and another camera head is behind the patient, and the table carrying the patient is moving slowly between those two camera heads, generating an entire whole body image anteriorly and posteriorly. Instead, in SPECT, we have the two camera heads rotating around the body. So the patient is on the table, and each camera head is going to stay about 30 seconds at each position, and then moves. And they move by about 3 degrees. You could move a little less to get better images, but it adds a lot to the imaging time. And if you move by more than 3 degrees, the images are going to look really coarse. So it's a pretty good compromise. So a basic traditional SPECT, if you have to cover 180 degrees with two camera heads, with 30 seconds per step, and each step being 3 degree increment, we need 30 minutes to do SPECT. Nowadays, with iterative reconstruction algorithm, they go faster than that, 15 minutes to 20 minutes. So in practice, when we take a 30-second or 20-second image in a certain position of the camera head, we get a quick little image in anterior and posterior. Then we rotate another oblique set of images and some laterals. And if we adopt what we call either filtered by projection or OSEM, which are iterative reconstruction algorithm, we can create a picture of the tomographic distribution of the radiopharmaceutical. And the term SPECT comes from single photon emission computed tomography. So tomos in Greek means cut, graphos, imaging. Emission, because we use the radiation, the rays emitted from a biodistribution in a patient. We use computers to reconstruct the images. And why is it single photon? Because in general, the radiopharmaceutical we use in SPECT imaging or in planar scintigraphy emit one photon. So it's technetium-99m that gives you a gamma ray of 140 kiloelectron volts with a 6-hour half-life. Obviously, some of the radiopharmaceutical have more than one gamma, but they have different energies. So when we do single photon emission computed tomography, we do it over a certain energy window to isolate a certain gamma. So how do we differentiate a planar image from a SPECT image? As you recall, in planar imaging, we have a profile across a lesion that has to be a contrast difference that has to be detected over a background amount of radioactivity. When we do tomographic imaging by SPECT, we are basically only using a slice of the tissue. We're removing the tissues that are behind and those that are in front of that slice. So what happens is we don't have all the front and back counts to contribute to the background. Notice how this background is lighter in color than it was with a single slice. So the benefit of this is that you have less background. The background is not as high, but you still have the same gradient that you're trying to detect. So this gradient in intensity becomes easier to pick up over background. So we had a moderate contrast here. We have an even higher contrast here. You had enough here to detect the lesion, but if you were in a low count or low contrast setting where the amount of radioactivity concentrated with the lesion was not much higher than that of the background, then the amount of contrast you're dealing with in planar may not be enough for you to detect the lesion. Whereas after SPECT it is. You have plenty. So that's the fundamental difference between SPECT and planar, where namely SPECT has a better contrast resolution than planar imaging. So it helps us with increasing lesion detectability and negative predictive value if the scan is negative. So if you have a young person with lower back pain, you don't see anything on planar imaging on bone scan, you're not done until you have done the SPECT, because very often the SPECT will be positive while the planar is not, because you can't see a subtle abnormality buried in intervening normal bony structures. So in order to have the better negative predictive value, you need to have a negative SPECT. I'm not going to go into the physics of planar imaging versus SPECT spatial resolution, but what you need to know is spatial resolution should be understood as follows. If you take a point source, let's say a Q-tip that you dip into technetium 99M pertechnetate, you have a hot little source and you put it in front of a gamma camera head. The gamma camera is going to show you a hot spot. The closer you put the Q-tip to the camera face, the narrower the appearance of this hotspot and the higher the peak. Basically, the counts are not distributed over as wide a surface. And we have what we call a point spread function, which is the response of the camera head to a point source of radioactivity. And the closer this point source is to the camera head, the narrower this point spread function becomes. Now, move on to the exercise where you put two Q-tips, hot Q-tips, next to each other. Resolving them, that's what spatial resolution is about, trying to tell one hotspot from another. And in order to do that, it depends on the spatial resolution of the camera. So the spatial resolution is how close you can bring two hot sources, two Q-tips, to each other and still tell them apart, so that you can see two humps instead of one on the profile. Since you already know that with one single hot spot, the closer you place it to the camera head, the narrower the point spread function is, you can picture those two little curves that are narrower next to each other. The closer you put the two Q-tips in front of the camera face, the better the resolution. The closer they can be to each other when you're close to the camera face. If you're further ahead, you have to put them further apart in order to tell them apart. So that's the basic concept of spatial resolution with a planar gamma camera. When you do SPECT, how does that translate into spatial resolution? Well, let's say you see this lesion you're trying to detect, let's say in bone, is closer to this camera head. So this camera position is going to give you the best spatial resolution. If you were to put two spots here, this one would do the best job at telling them apart. And this one would do the worst because it's farthest away. Now, when we do a SPECT, we take multiple individual planar imaging and amalgamate them through reconstruction algorithm to make a tomographic image. So it's obvious that the final result cannot be as good as that of the best camera position, because the other camera position are degrading the spatial resolution. That is why the spatial resolution on a SPECT cannot be as good as that of planar, because with planar we can try to come closer. We only have one camera position to consider. So why do we use SPECT imaging? Well, SPECT is added to planar imaging in order to either improve lesion detection for deep structures, such as the case of that lumbar spine pars defect in the young man, or this pheochromocytoma we saw in the MIBG scan. It can also be used to better localize an abnormality relative to its local background. It's not always enough, but sometimes it is. SPECT can also enable a relative and absolute quantitation of the concentration of the radiopharmaceutical, and I will get into details of quantitative imaging in a few slides. Finally, when you put together a CT with a SPECT camera, then you can characterize a lesion both on the basis of its functional appearance as well as its anatomic features. So now let's move on to some example of PET and PET-CT imaging. This is again bone imaging, and I'm going to contrast for you bone imaging with technetium 99M labeled methylene diphosphonate, which is the bone scintigraphy planar or SPECT imaging agent, with PET, and this is PET here. This is a maximum intensity projected image of a PET scan on the same patient, but this is done with a tracer called sodium fluoride. So F18 is the radiolabel. It's a positron emitter, and therefore we can do PET imaging with it. It localizes to bone in a similar fashion, gets bound to bone even better, and it gets eliminated out of soft tissue even better than methylene diphosphonate. But so that we have two ways of imaging the bones. We can do it with MDP and plain scintigraphy or SPECT, and we can do it with PET. With PET, it's with sodium fluoride that we inject. So look at this patient. Within a few days of each other, this patient had anterior-posterior bone scan, planar. And if you look at this, you see a hot spot in the neck here. So you wonder, could it be metastatic lesion? Could it be degenerative changes in the facet? Here you have a hot spot in your humeral head. Could be degenerative, could be metastatic lesion. You see a bit of urine, you see degenerative changes in the fingers, and there is, in hindsight, a very subtle focus here in the right iliac wing. The next step would be doing a SPECT scan, and we would see it there. Now, it's not a fair comparison because I'm not showing you the SPECT compared to the PET, but for illustration, this is the sodium fluoride PET CT images, attenuation corrected, and notice all the lesions that we see. We see far more than we did on planar imaging, but we see this one in the neck. We see this one in the right humeral head, elbow. We see several here in the pelvis, in particular this one in the right iliac wing, but we see one here in the lower lumbar spine and another one here near the SI joint. So many lesions. This one is an AC joint. So in order to best characterize this, though, we have to look at other imaging, such as CT scans. But I can tell you that this one, based on its location, there's really nothing benign that's going to occur here. It would be pretty exceptional. Same thing for this and same thing for that. These are metastatic lesions. The other one, harder to know. So I'll show you how we characterize them. For the other ones, we're going to use the CT appearance. So this one, the blue arrow in the lateral aspect of L5S1, correspond to this, the overlay images or the cursor triangulation, which show us at this point, when we put the cursor in here on the workstation, correspond exactly to the lipping that you see here at L5S1 on the left. So that's degenerative disease with commensurate increased bone remodeling. That's why sodium fluoride localized in greater proportion here. Okay, so that's a benign entity. This one in red is a malignant lesion that corresponds to this small sclerotic focus in the right iliac wing. And this that we saw here in the left neck, left cervical spine, correspond to this facet hypertrophy changes here, another benign finding. So we can image bone with methylene diphosphonate and planar imaging or SPECT CT, I will show you, but also with PET and sodium fluoride. So notice that these images have much better quality than even the SPECT I showed you for the 13-year-old athlete. Why? Because of the physical characteristics of PET without going into too many details. PET has much better resolution than SPECT. But in PET, you might say, why don't you use PET for everything? Well, because we don't have FDA-approved radiopharmaceuticals for everything in PET. We have far more available in SPECT. So how is a PET scan acquired? I showed you a few minutes ago how a SPECT is done. Well, a PET is fairly simple in concept. We're going to use a positron emitter. So it is a radioactive atom that releases a positron as part of its decay. We have access to many of them. Among them, fluorine 18, carbon 11, nitrogen 13, rubidium 82, gallium 68, copper 64, etc. And the most commonly used is fluorine 18, like the one used here in this fluorine 18 labeled sodium fluoride bone agent. We use rubidium 82 in cardiac perfusion routinely, doing stress and rest comparisons for people looking for ischemic heart disease, among others. We use gallium 68 as a radio label, for example, with a tracer called dotatate, gallium 68 dotatate, which binds to subestostatin receptor subtype 2, and we do neuroendocrine tumor imaging with it. but others are available, copper 64, nitrogen 13, carbon 11. These are very short-lived, so they have to be produced on site by on-site cyclotron. This one is produced with a generator. So we have a generator on site if we're going to do a cardiac perfusion imaging. This one is produced with a generator, but has an hour half-life. So it can be shipped once radio-labeled as part of a radiopharmaceutical. And F18 has a 2-hour half-life. So one of these radio labels is attached to a molecule in order to trace a certain physiologic process. You have all heard of FDG, fluorodeoxyglucose, which is an analog of glucose. Let's say you inject it to do cancer imaging in a patient. At some point, the FDG molecule has localized to soft tissues. It could be in a normal tissue, or it could be a normal biodistribution, or it could be in a cancerous lesion. Why do cancerous lesions have a higher proportion of FDG uptake than normal tissues? For most of them, not all. In general, due to their increased proliferation rate, that gives rise to increased glycolysis and therefore uptake of FDG, which is an analog of glucose. It can also be due to hypoxia in some settings. So once this FDG molecule is localized somewhere within the body, at some point, the F18 nucleus, F18 being the radiolabel of this molecule, is going to decay, releasing a positron. This positron has an initial kinetic energy, and it's going to want to travel, and it cannot yet interact with an electron until it slows down enough. Once this positron beta plus has slowed down enough, with F18, the initial kinetic energy is such that it travels 1 to 2 millimeters. At some point, it's slow enough to interact with the environment that's electron-rich, and a positron is going to interact with an electron and annihilate each other, their matter and antimatter of each other. And the mass gets transformed into 2 high-energy photons, and these high-energy photons have 511 kiloelectron volts of energy. And they take off in opposite directions, and the patient being here, we put basically banks of detectors on rings around the patient in order to catch those pairs of photons. And how do we make an image? Well, we basically are going to try to say this photon and pair it with this photon to try to say they both came from this positron electron annihilation. We have to make sure we don't pair a photon with the wrong one. So we use certain tricks. We know they travel at the speed of light. We know the distance between the detectors. So we know the delta t, the amount of time necessary to cross a gantry. And any pair of photons detected at a time interval separating them that's beyond that delta t cannot come from the same pair. And they use many other physical tricks and scientific tricks to improve the image quality. Once we know they came from the same pair, we can basically draw a line saying that the probability of the location for this positron electron annihilation was somewhere on this line. Now, it is not perfect because this is not where the FDG molecule was. It was 1 to 2 millimeters away. So, that's ultimately the best resolution could ever do. But in practice, we don't even get close to that. So notice that the energy involved here is 511 kiloelectron volt for both photons. In SPECT, we said single photon emission computed tomography. Here, we image pairs of photons at a time. Note the energy is 511 keV. In scintigraphy, the radiopharmaceutical we use have energies gamma rays that start at maybe 80 kiloelectron volt with thallium, going up to 140 kiloelectron volt for technetium-99m. Indium-111, 170 and 250 kiloelectron volts. Gallium-67 has 90, 190, 290 that we image. And the highest we image is iodine-131 with 365 keV photon. So still all of them much lower than that. For those who are curious, fluorodeoxyglucose, that's the workhorse of oncologic PET imaging, is a glucose molecule in which a hydroxyl group has been replaced by fluorine 18. It gets into cells through glucose transporters. It gets phosphorylated by the first enzyme of glycolysis and becomes FDG monophosphate, which is polar, cannot leak through the lipophilic cell membrane, and stays trapped in the cytoplasm. But FDG monophosphate, contrary to glucose monophosphate, is not a substrate for the next enzyme of glycolysis. And it stays there, and there's very little dephosphorylation taking place. So in other words, FDG accumulates in cells in proportion to their glycolytic rate. So with FDG, we, in a way, imaging enzymology. So how is a PET scan done? Those pairs of photons that are being emitted from the body, from positron emission and positron electron annihilation, are going to hit the detectors. But how do we get to making an image? Well, we put the patient in the gantry. We first use a CT beam of a PET CT to do a scout. The scout tells us how we're going to want our scan to be, where it's going to start, where it's going to end. Most scans are from the base of the skull to mid-thigh, but sometimes we do top of the head to toes, whole body imaging. Then we do PET acquisition, where the pairs of photons are going to hit the detector heads. We can reconstruct a grayscale image distribution, and we can read those. Those are called the non-attenuation corrected images. But because there's a CT in the gantry, we're going to do a low-dose CT, or even diagnostic quality if necessary. A low-dose CT over the same region has the PET acquisition region. And that CT image is going to be used to correct for the effect of attenuation that this attenuation had on the photons, the pairs of photons that were trying to exit the body. If they came from the lung, there's not much to stop them except the chest wall, because the lungs are low density. But if the lesion is in spine, there's a lot more attenuation, and therefore a lot of the photons that were meant to be detected did not get detected. So by using the CT image, which is generated at 120 kVp, much lower energy than the photons of 511 kV we're trying to capture, we're going to say, let's translate this map of attenuation for X-rays of 120 kVp. Let's translate it physically into an equivalent map for 511 kiloelectron volt, and which is what is done in a scanner. There are tables, there are ways of doing this translation. And then the CT is used to give us an idea of what the density would experience by high energy photon would be if we had that attenuation map. And we use it to correct the data set. So I've shown you how a basic SPECT is acquired, how a basic PET image is acquired, but most of the scanners we have now are hybrid scanners. They're PET CT and SPECT CTs. And these are older pictures, but the concept is the same. You have within the same gantry, both rings of detectors for PET or rotating camera heads. So notice in SPECT, you have camera heads in front and the back that can rotate, and behind it is a CT. Same for these. Here, 2 camera heads for PET, and a CT is here. This is a flat panel cone beam CT. Same thing for this. And this camera head can be oriented at 90 degrees, for example, for cardiac imaging. In PET, the detectors do not rotate. They are complete rings of detectors, small detectors, solid state, that cover the entire circumference of a ring, and multiple rings are placed next to each other. And the scanners that we currently use at UWMC at SCCA are the best in the world and have a 25 centimeter span coverage along the z-axis. So with a given table position, we can see 25 centimeters of the patient's trunk. All right, so any question at this point? All right, so I'll move on. And I've no way of checking the chat, so speak up if you have a question. A few definitions. So what is hybrid imaging? It's basically having access to a piece of equipment that has 2 different imaging modalities within the same gantry, PET CT, SPECT CT, and now they manufacture PET MRIs. They don't sell too well because they cost $7 million and have a $400,000 a year maintenance fee. And there's some challenges using it, but that's a separate topic. What is correlative imaging? Correlative imaging, as you know, is comparing the appearance of a disease or a lesion on different imaging modalities or on a single modality over time by repeating a scan over time in order to get more information about the lesion and through either its temporal evolution or its appearance on two different imaging tools. The concept of integrative imaging is really the integration of all available clinical imaging data for optimal care. And it means using hybrid and or correlative imaging together with signs and symptoms of the patient, type and timing of treatment, that is compared with the timing of the scans, because certain scan appearance can have two different meanings, whether, let's say, a patient is on chemotherapy or not. And you correlate also with biomarkers. It can be tumor markers, it could be functional tests, such as pulmonary function tests, etc. With this, you integrate information. And that is the hardest thing, but the most rewarding and the most important for patient care. Integrative imaging is really the future of diagnostic imaging. It's going to be central to patient management in most areas of radiology practice. It's going to be rooted in pathophysiology and understanding of the disease process and its appearance across multiple imaging modalities. In the past, integrative imaging was pretty limited. It was because we were dealing just with anatomic imaging. For example, you had a patient come to the ED with right flank pain, and you'd find a stone and obstruction on a CT scan if you had given IV contrast, or just a dilated ureter above a stone and a non-con CT KUB. That was correlating sign and symptoms with imaging. In tumor response, we would correlate tumor markers with changes in either the number and size of lesion at CT. But there's limitation to this because, for example, we often see new sclerotic bone lesions on CT scan over time has, for example, breast cancer patients' tumor burden decreases. But if we just look at the CT scan, we have the impression that there are new lesions. Well, in fact, the sclerotic lesions are the response of normal bone to a lesion that often was subclinical, not visible at baseline on CT, that was starting to erode the bone. And once the cytotoxic chemo has killed the cancer cell, the bone has a chance to buttress, heal itself, and appears as a sclerotic focus. But the sclerosis is only a hallmark of treated disease in that setting. We would do integrative imaging when we would compare patterns of interstitial lung disease at high-res CT with pulmonary function test. And that goes up to so far, but it can be done to an extent. So in integrative imaging, we use both functional and anatomic projections of a disease in order to enhance our ability to practice accurately. So to illustrate this concept of sclerotic bone lesions, this is a patient who had breast cancer. Prior to therapy, you notice there was already a bit of sclerosis here and here. After therapy, the repeat CT scan shows a new sclerotic lesion here. In the old days, prior to PET, we would have said, oh, there's a new lesion here, that's progression of disease. Turns out that these two lesions, these two slides I'm showing you are actually part of a PET CT scan performed before and after therapy. Notice that before therapy, there was a lesion here. After therapy, the lesion is no longer visible on FDG PET, but the area where the lesion was present has developed sclerosis. Okay, so the sclerosis is here a hallmark of treated disease, not a measure of current burden of disease. And that's why often in the old days, the oncologist would say, well, you're saying there's new lesions in bone, but the tumor markers are going down and the patient is feeling good. So I'm continuing my treatment. So now in the last 20 years, with the advent of using FDG PET, commonly in the management, for example, of this breast cancer patient, we have much better understanding of the relationship between therapy and disease burden and tumor markers. So hybrid scanners give us really an opportunity to do many different things. Realize that when you have a PET CT scanner and let's say 7 different tracers available, every time you inject something different in a patient, it's like you have a new scanner. You have a new tool. In contrast, if you have a CT scanner, which is a great tool, it's contrast, no contrast, a little bit degree of freedom, how much you inject, but how fast you inject it and when you catch it more than once. But it's always the same contrast, identical contrast. In MR, you have a couple of choices. Again, in PET, or SPECT, every time you inject something different, it's like you have a new scanner. And that's the power of the technique and understanding the physiology that is underpinning each radiopharmaceutical and the pathophysiology of each disease is essential in order to exploit those tools properly. So the synergy between PET and SPECT, or SPECT and CT, can really help overcome diagnostic challenges. It gives us a more accurate, timely, and comprehensive care. Quantitative imaging is also possible because once you have generated the basic PET or SPECT image and you use a CT scan for attenuation correction, basically compensated for the absorption of photon exceeding the body before hitting the detectors, you have attenuation corrected images that can be normalized to the injected dose. And that allows you to obtain certain figures of merit. On PET, we call it the SUV, standard uptake value. In SPECT, I like to call it the SPUV, single photon uptake value, to not confuse them. And they are basically measures of the concentration of radioactivity per unit volume normalized to the injected dose over the patient body weight. So, and these are objective measures that can be followed over time. And so PET CT and SPECT CT are quantitative imaging tools. So that's a very important message to take home. So when we practice with PET or SPECT, what do? We first look at the PET and SPECT images, identify scan findings, look for a pattern potentially in the disease distribution. We form an initial differential diagnosis together with CT findings. And we narrow with the CT finding our differential diagnosis together with the correlative imaging and clinical data to get to a final impression. 7 traces available for PET, 30 for SPECT. So what advantage do these have in common? So the multiplicity of radiopharmaceutical, I should call them. So 7 of them available for PET CT, and there are many more for research applications that are not yet FDA approved. Some will never be because there'll never be enough clinical data to get them approved. There are 30 FDA approved commercially available SPECT radiotracers, and even more in Europe and in Japan. Some SPECT radiotracers are currently underused, where you don't see them much in clinic. And why? Because there's been a historical competition from an anatomic imaging exam. For example, we don't do anymore MAX3 renograms in renal transplant, as Dr. Matesan was showing you. It's a very good tool, but it's not used. People either use Doppler ultrasound looking for changes in resistive indices or power Doppler, and otherwise they'll do biopsies. So often competition with another exam gets a radiopharmaceutical to be underused or in disuse. Sometimes it's due to low specificity because there was not a concurrent anatomic image. But in the era of SPECT CT, where CT is overlaid with a SPECT, then they get reintroduced. And that's what we're doing across many different applications that I will show you. For some others, the inability in the past to calculate, to do attenuation correction in SPECT and to extract uptake values was limiting the applicability of the technique. So nowadays, with SPECT CT, we can reevaluate all tracers in an updated clinical context of new therapies or of updated understanding of a disease biology to determine its role and to also apply quantitative SPECT. So all these hybrid imaging systems have things in common. They allow us to compare disease appearance on functional and anatomic images for improved specificity of interpretation. They allow us improved localization of tracer uptake. They allow us to narrow differential diagnosis by intersecting anatomic and functional differential diagnosis. Because if you look at a disease from the point of view of a CT appearance, you say, okay, the differential diagnosis would be the, you look at it from the functional image standpoint, the differential is going to be different. And at the intersection of the two is going to be a much more precise diagnosis. What we can do also is to generate a diagnostic anatomic exam in the same session. For example, half our FDG PET CT have a concurrently ordered contrast enhanced CT of the chest, abdomen, and pelvis, sometime of the neck as well. And they are done in the same setting without the patient moving. It saves time for the patient. It saves only one IV, one travel, and all the imaging is interpreted at the same time so that you don't have discordant impression, such as the example I was giving you of sclerotic bone lesions in CT in FDG PET CT of breast cancer patients. The ability quantitative tracer uptake from attenuation corrected images is another common strength of all hybrid imaging tools. PET-CT and SPECT-CT. This uptake metric can be used for different things: to determine whether a process is normal or abnormal, to grade or risk stratify a process by comparing uptake to a database. That would be from a prognostic standpoint. To objectively follow a disease process over time and during treatment. That is the most common use. For example, in FDG PET, we're not going to make a determination whether something is benign on the basis of the SUV. And if somebody ever tells you that anything above an SUV of 2.5 is cancer and below it's not, that's heresy. Just get that off of your mind. What's important, however, is comparing the SUV of a lesion over time when the patient has been scanned both times on the same machine with the same protocol in the same conditions. That has meaning. And in general, a 20% change in an SUV at PET is a meaningful, statistically meaningful change. It has a biological meaning. In SPECT, you should expect those required delta to be larger because it does not have the same accuracy without going into detail. But we don't know yet the exact delta that's necessary from a quantitative standpoint to reflect truly biologically significant changes in SPECT. And it's going to depend on the tracer and the energy. You can also conduct, once you can do quantitative imaging, you can conduct hypothesis-driven research with established radio tracers or to validate new ones. So a few examples in PET-CT, and then I'll show you additional applications in SPECT-CT quickly. We have 7 clinical radiopharmaceutical in PET, and they're applied to oncology, brain imaging, for dementia workups, cardiac assessments, and sodium fluoride to oncology for looking for bone lesions. But sodium fluoride is no longer reimbursed by Medicare, so it's not used much. The impact of the uptake metrics, let me show you some examples. You can use ammonia, N13 labeled ammonia PET-CT in cardiac imaging to determine coronary flow reserve, and it has prognostic value. I will show you a slide of this data. You can use partial volume corrected FDG uptake of primary lung cancer, for example, and correlated with histologic subtype, level of differentiation, or even the proliferation rate assessed at Ki-7 immunohistochemistry. These have meaning. These correlations exist. However, for example, if you extract the max SUV or partial volume corrected max SUV of a primary lung cancer and compare it to that of others, among resectable tumors, it is not prognostic. It is not going to predict which one's going to recur. We studied this at great length. So let's go over a cardiac example. This one is rubidium, but the same would be with ammonia. This is a patient that had cardiac perfusion imaging with rubidium-82. This is the rest images. These are the stress images with a vasodilator. And this is a very short-lived radiopharmaceutical. Notice that during the stress portion, there are areas of the myocardium that don't have as much uptake, anterior septum, etc. Whereas at rest, we're looking on short axis. This is the apex. This is the base of the heart. And this is the membranous septum, so we don't expect any uptake here. So this is uniform across here, whereas this was not. So these are areas of ischemia. The dark purple here that are not orange are areas of ischemia. This is the same data set projected in vertical long axis. This is the anterior wall. This is the inferior wall. This is the apex. And here in horizontal long axis, apex, septum, lateral wall. So when you study what's called a coronary flow reserve, what do? You take the images of the patient at stress, images at rest, and you study it by standardized segments around the periphery, and you take the ratio of blood flow at stress divided by blood flow at rest. And that ratio, called the coronary flow reserve, should be greater than 2 in normal tissue. And why is this important? It's because it has prognostic value. There's a fellow called Herzog a few years ago, about 10 years ago, published a nice study where they looked at nitrogen-13 ammonia, PET perfusion of the heart. They had 256 patients, and they had major adverse cardiac events such as death, myocardial infarction, or hospitalization for cardiac symptom that were recorded. And they correlated this with the coronary flow reserve in these patients. And they showed that in patients that had abnormal coronary flow reserve, which is the black one here, versus normal CFR, the incident annually of major cardiac events was much larger in the patient that had abnormal CFR, less than 2, whether it was MACE or cardiac death. So having a abnormal coronary flow reserve is going to predict major cardiac events. So first example where quantitation is important in PET-CT and has prognostic value. Another example of quantitation, this one is not with a flow tracer, but with a glycolysis tracer, FDG, fluorodeoxyglucose. For most lesions that are under 2.8 centimeters, FDG uptake is falsely lowered by the limited reconstruction resolution of the scanner. This is something we studied on older scanners. On the current scanner, it's going to be better than this. If you take a bunch of little spheres of calibrated size and you fill them with a known concentration of radioactivity, FDG, let's say, and you put them in a cylinder with cold water, water without radioactivity, so what I mean by cold, and you image them for a long period of time to have very low noise in your data set, you are then going to measure, let's say, an SUV of each of the lesions. You know what the concentration of radioactivity is because you measured it in a dose calibrator, and so you therefore know what the truth is. And if you take the concentration measured by the scanner in each of those spheres, divided by the truth that you should be finding, you're going to realize that when the lesion is large enough, the scanner is accurate. The ratio is 1. It is measuring what it should be finding. But as the lesion is getting smaller, the ratio drops. And for on older scanners, but for a 1 centimeter lesion, it's 0.25, which means we are only capturing a quarter of the concentration we should be finding. So all this to say is when you image a small lesion, let's say a small nodule in the lung, and it may be malignant, but look only mildly hypermetabolic. So don't go and say, oh, it's under 2.5 max SUV, therefore it's benign. Because if it's small, the number you're actually registering with the scanner is falsely lowered by these partial volume effects, namely that the size of the lesion is much smaller than the reconstructed resolution of the scanner. There are ways of correcting for this, and by invoking the recovery coefficient, which is basically a recovery factor, given the size of the nodule you're imaging, and the background uptake in the surrounding tissue. So how have we applied this over time? Years ago, through a couple of NIH grants, I studied non-small cell lung cancer because 50% of low-stage resectable non-small cell lung cancer that get a complete, presumably curative resection recur. And 80% of these recurrences take place within the 2 years that follow. So we were interested in trying to figure out, can we predict those patients who are going to recur? And the whole idea is if you could predict it, those would get adjuvant chemotherapy over others. Now, adjuvant chemotherapy is given to patients with stage 2 routinely. And so what did we do? We studied patients who were going to the operating room, and we had their stage by PET, surgical stage, and then we followed them over time and related the uptake of the primary tumor on a preoperative PET to normalized for stage to the outcome. And it turns out that the uptake of the tumor, whether it's partial volume corrected for size or not, does not predict outcome. It does not predict, it does not have predictive value beyond the size of the lesion, and it does not improve on the prognostic value of tumor stage. So you cannot say that harder tumors are more likely to recur than less hot tumor. Size for size, stage for stage, you cannot. So let's talk about other approved radiopharmaceuticals. I've mentioned to you that we use FDG for cancer imaging. We use it for dementia workups. We can use it for cardiac viability. We have rubidium or ammonia for cardiac perfusion. And I mentioned sodium fluoride for bone imaging. 2 years ago, gallium-68 dotatate was FDA approved. And it is a tracer that binds to somatostatin subtype 2 receptors and that are present in neuroendocrine tumors. They're present in many other things, in small cell lung cancer. They are present in meningiomas. They are present in, quite a few entities. non-iodine avid thyroid carcinoma, also in medullary thyroid carcinomas. So a couple of examples. This gallium-68 labeled dotatate tracer, here in an 84-year-old female with a orbital neuroendocrine metastasis and unknown primary. You could see clearly this lesion in the orbit here on the overlaid image, right here, and here on the frontal projection. And this patient had both a bowel primary and nodal metastasis, okay, to these lesions. So what is a normal distribution of gallium-68 dotatate? Well, pituitary gland, salivary glands, thyroid, adrenal medulla, liver, spleen, bowel, kidneys, and urinary bladder. It is excreted by the kidneys. That's why you see it here and in the bladder and in the ureters. Pitfalls are going to be the unseeded process. Gallium dotatate binds to the unseeded process, and whereas other chelates, such as DOTA-TOC or DOTA-NOC, which are also used for neuroendocrine tumor imaging, do not have this false positive in the unseeded process. So be careful to not overcall a lesion in the unseeded process when you do dotatate imaging. Obviously, splenic tissue, such as you can have accessory spleen giving you, fooling you. Infectious inflammations will have dotatate uptake. Why? Because activated macrophages have somatostatin receptors. And so many chronic or acute infection or inflammation will have dotatate uptake. Vertebral hemangioma and lymphomas as well. So this is another example, that of a 60-year-old lady with a liver mass found incidentally at workup of a renal mass. And the biopsy was a proven neuroendocrine tumor, but the primary was unknown. And by dotatate PET imaging, focal uptake was found in the ileum and surgically proven with a Ki-7 score of 15%. The renal mass with a clear cell carcinoma. So you see one liver lesion here over the background normal uptake, as well as this lesion here in bowel. Very difficult. Nobody would call that on a CT scan. Sometimes if you do a pretty early arterial phase imaging, or if your portal phase is a little too early, you will see arterial enhancement of the lesion in the bowel wall. Why is it that we are referring to the Ki-7 score? The Ki-7 antigen is expressed during the cell cycle, during several phases of it, and we still don't know exactly what it does, but it turns out that we have an antibody called MIB1 that binds to it. And the more cells bind MIB1 means the more cells are cycling. And the pathologists count at immunohistochemistry the number of cells per high power field that are staining positive for MIB1 antibody, which means the percentage of cells that are actually in proliferation. And turns out that well-differentiated tumors that have a low proliferation rate will have high dotatate uptake, will be easily seen on dotatate PET imaging, whereas the poorly differentiated ones, because they're poorly differentiated, they grow fast, and they have very little in common with the parent cell they originated from, and they often don't have somatostatin receptors anymore expressed on their surface and will not bind dotatate. As a result, they could be false negative. So in general, most of these neuroendocrine, endocrine tumors that have this higher function that we exploit for imaging, the poorly differentiated ones may be false negative, whereas the well-differentiated one will be positive at dotatate imaging. The corollary of this is that if you did FDG PET, the poorly differentiated ones, because they grow fast, they may not have somatostatin receptors on their surface, but they grow fast, they have high proliferation, downstream high glycolysis, and they will be hot on FDG PET. At the other end of the spectrum, the well-differentiated neuroendocrine tumor may not be visible at FDG PET, but easily seen at dotatate PET. Another quick example, 50-year-old male with recurrent abdominal pain and GI symptoms since 2005. CT was positive for liver lesion. The biopsy showed metastatic carcinoid in the liver, primary unknown. So you clearly see the lesion here on contrast CT, and here it is on dotatate PET. The dotatate PET also revealed the presence of the primary, which was right here in the distal ileum, okay? Likely the primary lesion. And you often, with neuroendocrine tumors, see this star-like, stellate-like lesion in the root of the mesentery. Sometimes residents think, oh, here's the primary. No, it is not the primary. It is a lymph node that is draining the primary. The primary is usually very hard to see. It is at the mucosa. And this relay lymph node, because of serotonin release, is often associated with a lot of desmoplastic reaction scarring, which makes them look stellate-like. Another example here of a patient with a lesion in the right symphysis pubis, not visible on CT scan, and another one here in the right side of the sacrum, not visible on CT scan, and another one in the proximal femur. So these are powerful tool in finding early metastatic lesions at a time we often don't see any changes on CT. Another one as well. This one was missed on 8 prior CT scan, and here's the sacral metastasis. Another tracer available for PET is FECBC, also known as fluciclovine. It's F18 label, and the commercial name is Axumin. It's a synthetic peptide, and we use it for prostate cancer imaging. Why? Because amino acid transporters are upregulated in prostate cancer. The normal biodistribution of fluciclovine is in the liver, the red bone marrow, lungs, myocardium, pancreas, and within the first 4 hours post-injection, 3% is excreted in the urine. So what do? We're going to start the imaging 4 minutes after injection instead of waiting, let's say, an hour for a DG PET. With this, we want to overcome the urinary excretion because we don't want that to mask any nodal uptake or prostatic bed recurrence. So we're going to scan the patient starting at 4 minutes after injection from the pelvis up. It gets taken up by muscle. So notice the upper part of the body was imaged several minutes after the lower part. And so that's why you already see muscle uptake. So I'm not going to spend too much time on the protocols. When you rotate on PET, you will have access to them. But it's really important to center the prostate gland or the prostatectomy bed in the first bed position due to the fact there is rapid urinary excretion of this tracer into the blood. This is usually recommended for patients who have had a complete treatment or presumably curative treatment of their prostate cancer. Could be from prostatectomy, chemotherapy, radiation seeds, and who have androgen deprivation therapy, but still a rise in their PSA. Sensitivity is best when the PSA is at least 2, but we have seen many cases of subtle disease with lower PSAs. It all depends how the disease is distributed. If you have a PSA of 1 and the disease distributed in 20 different small lesions, we may not be able to see it. But the same type of tissue distributed in a single lesion, we may be able to pick up. This is an example of increased Axumin uptake or fluciclovine uptake in the prostate gland, consistent with recurrence of prostate cancer, a patient who has had seeds. This is an example of local regional recurrence in a patient who had external beam radiotherapy, and he has uptake in the seminal vesicle. And you can see we follow the PSA level carefully. This is a patient who has a pelvic sidewall node of recurrence in 80-year-old status post brachytherapy with pelvic external beam radiotherapy. In this patient, the PSA was rising, and we found this enlarging pelvic node. When you read a lot of fluciclovine scans and you review the patient's serial CT, you learn to appreciate that prostate cancer recurrence can be very subtle. So when you're going to read a prostate cancer CT scan, look for nodes that are not necessarily enlarged. Sure, you're going to look for the enlarged ones, but look for those that are slowly creeping up in size. They could go from 2 to 4 to 6 millimeters. This over a period of many months or years. These are the suspicious ones. And we appreciate that by seeing them light up on flucyclovine. Another example, this one of a patient with a perirectal fat lymph node. This patient had a PSA of only 0.4 nanogram per milliliter after the robotic assisted prostatectomy. And there's focal uptake in an 8 millimeter perirectal lymph node. Because of that, the patient, they were planning for salvage radiation, but it may be difficult due to the proximity of the rectum. So this area is difficult for urologists and may not be surgically approachable. A few years back, we had a patient who had, prior to flucyclovine being FDA approved, we'd gone to the Mayo Clinic for a C11 choline scan, carbon 11 choline scan that had been performed there. And there were two small foci in the perirectal fat. And these are nodes that had grown from respectively 2 to 4 millimeters and 4 to 6 millimeters. In order for them to be able to find them in the operating room, I suggested to the surgeon that on the way to the OR, we position a red rubber catheter in the rectum under CT guidance and inflate the balloon at the axial level of the two nodes. So in the operating room, they could feel the balloon in the rectum and dissect the fat, lateral to it. And that's what they did, and the PSA dropped. Otherwise, it's very hard for them to find this. Another example, some of these cases were given to me by Sanaz, who had collected some nice ones. So this 75-year-old has a history of prostate cancer, cyberknife treatment to lymph node, and now has a rising PSA and is presenting for restaging. The flucyclovine scan revealed 5 and 9 millimeter nodes with increased flucyclovine uptake, consistent with nodal metastasis in the aortocaval and left parotid stations. So I think I want to know, when does your session finish? Hello? Okay. Should I continue?
I think we
Dr.
normally
Vesselle, I
end at
think.
5:15.
Oh yeah, 5:15. I was gonna say the same thing.
Okay.
I think. Yeah.
We have
Yeah,
we
I
have
think
another
that's right.
we have another 10 minutes. Okay. So another example of a flucyclovine scan. This one is a subtle focus in the lung, and this one was a metastasis. It's very rare from prostate cancer. You will also identify certain other malignancies. Sanaz, Dr. Benya came across a HCC on a flucyclovine PET scan, incidentally found. I came across a 7 millimeter mid-body pancreatic cancer, incidentally found at flucyclovine PET imaging. So, a lot of tumors will have amino acid transporters that are upregulated. And so it's not surprising that flucyclovine would be taken up, not just in prostate cancer. So with respect to prostate imaging, what you should expect is that we will have a new radiopharmaceutical that will be even more specific, which is going to be either gallium-68 or F18 label PSMA, prostatic specific membrane antigen. And we expect that to be approved probably by December of 2020. So it is much more specific, has much better contrast to background, and it's likely going to displace flucyclovine, and it will become the premier PET imaging agent for prostate cancer. I'm going to take 5 minutes to show you a few clinical applications of SPECT-CT, hybrid imaging. So we talked about the fact that there are 30 tracers existing. So I'm not going to dwell on this. And the capability to do quantitative imaging. We're just touching the surface of quantitative imaging with SPECT-CT, but it will help us follow physiologic process over time and determine if they are going in the right direction when therapy is administered to a patient. Let's move on. A few examples. So this is a patient with bilateral pars defect. Okay, notice the bilateral pars defect here, but only the left one has uptake at SPECT-CT. So this patient was braced. As I mentioned earlier, there's benefit to bracing the patient for 6 weeks to 6 months in an attempt for this to heal on its own. by stopping, unwanted movements at that level through the brace. On the other side, on the right, the green arrow points to another pars defect, but that one has no abnormal uptake. That one is not going to heal on its own. We use SPECT-CT in prostate imaging for bone, as I mentioned to you earlier. Notice this SPECT-CT of the pelvis. You can see lesions here in the inferior pubic ramus on the left. There's no sclerosis here. So this should not deter you from calling this a metastatic lesion, okay? If it's more advanced, you might be able to start seeing some sclerosis, but not seeing sclerosis on the corresponding CT image does not mean this is not a metastatic lesion. It is a metastatic lesion, okay? So this is an example of a male, obviously, with prostate cancer metastatic to bone. I'm sure Dr. Benya covered this. This is a classic axial distribution of prostate mets through Batson's plexus. They start in the pelvis and lumbar spine and ascend. It is less common to see it in the appendicular skeleton. And serial bone scans are used to determine the progress of disease. However, in some instances, it's difficult to objectively set the image intensity on planar scan for meaningful comparisons if the changes are subtle. If you have new lesions, or if they're frankly worse or frankly better compared to the normal areas that are not involved, that's easy. However, there will be settings where the changes are subtle. And so it would be nice to be able to use whole body attenuation-corrected SPECT-CT to improve the accuracy and evaluating the relative changes observed on serial scans. But it takes extra work, and it makes the scan a lot longer than the planar imaging. Infection imaging. We have the ability with SPECT imaging, contrary to PET, to image multiple energies. We can set the energy window. So the advantage of this is that we could inject two different radiopharmaceutical in a patient with two different radio labels and image them separately by doing a dual acquisition with different energy windows. Case in point. This is a patient with painful right total knee arthroplasty. And the question was, is this loosening? Is this osteomyelitis or septic arthritis? So what the patient had at the junction of the on bone scan, SPECT-CT, of the femoral component and tibial component, there was increased uptake. Some is expected due to the bone remodeling that happens. Now, in order to prove there is no infection, we have to do a white blood cell scan. So we injected 0.5 millicurie of indium-111 white blood cells. That's a label. It's a small amount of indium-111. We injected it, and we scanned the patient at 24 hours. And we do a SPECT-CT on the energy windows of indium-111, which are 170 keV and 250 keV. This is a color rendered imaging of this white blood cell distribution. And you see increased uptake here and here. The question becomes, well, does this mean there's infection? And the trick here is you can have increased white blood cell accumulation on the basis of infection, but also on the basis of bone marrow expansion. And you know that when you read an MRI, there are cases where you have increased enhancement on T1 weighted post-GAD, and that does not necessarily mean that there's infection. Some of them are also false positive due to marrow expansion. It was not recognized in the early years of MR, but now well understood. Same issue here. So what do we do to know if the white blood cell accumulation is due to marrow expansion or to local infection? What we do is we do also what's called a sulfur colloid scan. Sulfur colloid is taken up, it's technetium-99 label. It's taken up by the reticuloendothelial system, basically liver, spleen, and bone marrow. And if you have an area of bone marrow expansion, then you're going to have increased sulfur colloid. And a concurrence between increased white blood cell and increased sulfur colloid means that's just marrow expansion. But if you have an area with increased white blood cell count and no increase in sulfur colloid, that is not due to marrow expansion, it is due to infection. And that's what you see here. This is infection. This part here corresponds to this. But this part has no counterpart on the sulfur colloid scan. And so we told them this patient had infection. They took the patient to the operating room, and they actually found coagulase negative staph at culture of the excised prosthesis and synovium. There was actually a couple of the foci in the synovium that are hard to show on this. So with SPECT, we can do dual energy imaging, which means we can image 2 tracers. Get the patient's white blood cell one day, radio label them, re-inject them. The following day, the patient is imaged at 24 hours, gives plenty of time for a biodistribution of the white blood cells. And at the same time, you inject sulfur colloid. And you image both the sulfur colloid distribution by imaging the technetium 99M photopeak of 140 kV and the white blood cell distribution by imaging the indium 111 photopeaks of 170 and 250 keV. I think I will stop here to not go over. Know that there are other applications of SPECT-CT since we have 30 tracers. We have made the headways in using them for multiple pulmonary applications in congenital heart disease. We use them for planning Y90 microsphere treatment by planning MAA mapping. We use them for treatment planning for radiation therapy, external beam in the chest, as well as in the liver using sulfur colloid. So there will be more as you go through your residency, and feel free to approach us with questions. Any question at this point? Any question? I'm glad to see I did not lose too many people.
Thanks, Dr. Vesselle.
Okay, Grace, you're welcome. No question? You're welcome.
Thank you.
Thank you.
Thanks, Janice. Bye, have a good evening.